think understanding that you can have damage in your body but not have pain, and you can have pain and not have damage is, I think, a very important concept for people to understand and an important myth to discuss. Welcome back, every Bendy Body, to the Bendy Bodies Podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained physician dedicated to helping you navigate Ehlers-Danlos syndromes, joint hypermobility, and complex chronic illness. Today, I'm joined again by Dr. Dacre Knight, who is not only an expert in EDS, HSD, POTS, and mast cell disorders, but is also joining me as a recurring co-host. Today, we are going to be talking about some common myths related to EDS, HSD, POTS, and MCAS. As always, this podcast is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Let's get started. Well, I am so excited to be back with Dr. Knight, who is the medical director of the UVA Health EDS and Hypermobility Disorders Center. Thank you so much for joining me again.
Thank you. Yeah, always a joy and a pleasure to be here.
Wonderful. Well, I'm super excited about this conversation because we hear so many different myths, right? Myths about EDS, myths about joint hypermobility and POTS and MCAS and all the things. So we're going to talk about a lot of those myths today and see how many of them we can bust.
MythBusters, the EDS version, right?
Yes, exactly. MythBusters, EDS version. So I want to start with one of the really, really important ones, and then we're going to kind of get into some more general things that maybe you feel like you really want to, say, hey, this is a myth that I hear all the time, and let's just clear this up like once and for all. But let's start with something kind of specific, which is why, people say, oh, well, no, EDS isn't serious unless it's vascular. I feel like this is a myth that persists. And of course, we know that vascular EDS is very serious, but so are the other forms of EDS. So what are your thoughts about that myth?
Well, for sure. And that is a myth indeed, because, how do we put it in context of what's serious? I think that's the question, because historically, my take on it is that medicine has, defined severity by immediate mortality risk, right? We think about emergency situations, chest pain, right? Call 911. And so it's got this relationship. But it hasn't really had that relationship with long-term disability. And that's where we see the hEDS and the hypermobility disorders fit into. Because while, yes, vascular EDS and some of those other rare severe types certainly are dramatic and life-threatening, these other types, common types, they can certainly cause chronic multi-system impairment that is less visible, but certainly has a tremendously profound impact, and certainly that impact is long lasting.
And I'm sure you've had patients and or heard stories about people who have passed away related to complications from EDS, right? So even though hypermobile EDS itself is not technically considered life-threatening, although my life insurance company sure did view it that way when I was trying to get life insurance and they saw hypermobile EDS on my medical records and they didn't want to insure me. So that was interesting.
Yeah, well, that's the whole point of what we try to do is recognize it when it is manageable, right? Because it's not severe until it is. And we don't want to let it be severe.
Right, exactly. And there's people that have, because they've ended up with central lines and things like that, and then they get an infection or get septic or whatever. There's a number of cases that I am aware of young people in their 20s that have passed away due to complications from hypermobile EDS. So it's just so important for us to know that these conditions are definitely serious. They can carry some very serious complications. And for our clinician colleagues to be aware that when, especially like we talked about in a previous recording, especially when we don't address things at an earlier stage, that can lead to other sequelae that can really be problematic.
Absolutely. Yeah. And as we just said, we don't want it to be problematic. So that's why we have to really do our due diligence to recognize these things as early as possible.
And there's a lot of myths around genetic testing also. So, what do you want to say about the myths about genetic testing?
Well, there is because I think that what that lies in to bringing up is kind of the questions about when we come to treatment or testing. We want the quickest answers. We want the most complete answers. It's going to give us the best description of what's going on. And the problem is genetic testing, while it can be very accurate, very specific, if we're looking at specific mutations or variants on specific genes, it can answer a lot of questions. We have certain subtypes and identified mutations for those subtypes, but it cannot rule out conditions like hypermobile EDS, where the genetic basis is still unknown. And hypermobility spectrum disorders are likely much more multifactorial than just genes. So while there may be an influence, there could also be epigenetic or environmental, external exposures that affect our genes, and so that differs from person to person, really, whatever condition they're living in. So while genetic testing is helpful, it's not always the most helpful that we want it to be.
And when do you think that genetic testing is indicated in people who are presenting with symptomatic joint hypermobility? Because I feel like, at least for me, that needle has moved over time. So what are you currently doing about that?
Well, yeah, as the proverbial needle moves, and I would love to see it continue to move in that direction, that we have more of these testing capabilities, that we have quicker and easier and more accurate genetic testing, because I think it can fit in well into a precision model of healthcare where we are able to do some testing to figure out the differences from one person to the next. We're not all the way there yet, but I'm hopeful that that's where we'll get. So right now, where we are is we have to look at the patient and their medical history and their family history to infer any red flags that may be evident. So, history of sudden death in someone who's young in the family, history of aneurysms in immediate family members. We talk about immediate family, meaning, parents, siblings, and children. And then those can inform us whether there is a genetic disease that may be present, that may be found on genetic testing. But ultimately, if we have a negative test result, that doesn't mean you don't have EDS or hEDS or hypermobility spectrum disorder. So we always have to be thinking about that next step too.
And I think that's another one of those myths that continues out there, which is that a geneticist is required in order to diagnose hypermobile EDS or HSD. And neither of us are geneticists. And of course, we have diagnosed plenty of people with hypermobile EDS and with HSD. And so I think it's just important for people to be aware that what really is required is a person who has, well, first of all, the ability to diagnose, right? So the person has to be an MD, a DO, it could be a nurse practitioner or a physician assistant, right? As far as I know, that those are the basically four categories. And then also the person has to have the right knowledge and training and time to do the proper assessment in order to make the diagnosis, but they don't have to belong to any particular specialty.
Right. And certainly these areas too, where there is still a huge unmet need, it's really any specialty who's willing to take the time to learn and understand and educate themselves on the diagnostic evaluation, the criteria and things like that, it can really be any of those, like you mentioned.
Yeah, because that's another myth that, these conditions are rare. Of course, that's like probably the biggest myth there is, that these conditions are rare. And also that a lot of clinicians won't be seeing patients with these conditions. But I would argue that every clinician, regardless of your specialty, virtually every clinician is going to see people who are somewhere on the spectrum of symptomatic joint hypermobility, whether they meet the full, current 2017 diagnostic criteria for hypermobile EDS or not. Of course, we have the road to 2026, so we'll see what that new criteria looks like. But regardless of your specialty, if you're a clinician and you're listening to this right now, I pretty much guarantee that you have these patients in your practice. And once you start seeing them, you won't be able to unsee them.
And ideally, then you can provide them the tools and resources to help them. And I think patients then just understanding that there is someone who's learned and has listened to them and has then the knowledge to try to help them rather than just referring them on to the next provider. I think it's a huge bonus for those patients.
So a lot of times patients will come to me for their first appointment and they will share results from direct to consumer quote genetic testing. But I really worry about the accuracy of those results. And I have discussed that with both Dr. Claire Francomano and Dr. Paldeep Atwal. What are your thoughts on those types of testing processes?
Yeah, I'm in the same group of thinking as they are, and I generally in my practice I generally find them less helpful than helpful. And there's a couple things at hand. One that you mentioned is it's hard to discern the reliability of that testing site and what they're doing and how they're doing their testing, and so that can vary. I mean, there can still be some good ones out there. But there's also this added anxiety too that comes with unexplained test results and what it means. And that's not to say that, we want to ignore the fact that there may be, something at hand. We just want to go through it in the right process where patients can get the counseling and feedback that may come with any result. And so that's part of the whole consenting process that we go through when we consent patients for genetic testing is that their awareness of what they may find or may not find and the ramifications of testing. So I'm generally pleased to see that the technology is expanding and it's growing in availability and the cost is coming down. But I think we still have to be very careful of how we're doing it, and we still have to be very careful as always as the analogy of snake oil salesman has been around for many years, that there's still plenty of people who would be very willing to take your money, if they are espousing these, great visions of all of the answers being explained to you, through whatever testing service they offer. So just, be careful of it. And we certainly as providers want to have everyone as informed as possible, and we can counsel them when they see us.
Yeah, and I've noticed too that they'll often have like a little asterisk at the bottom, not to be used as medical information or something like that. But at the same time, then they'll say, "Well, yeah, this gene is consistent with hypermobile EDS," and it's like, "Well, wait a second, but we don't know the gene or genes for hypermobile EDS yet." So it's that's something that definitely I think needs more study and exploration because because they are desperate, they are resorting to more and more of those kinds of tools on their own.
Yeah, I've seen that a lot for sure.
Yeah. What other myths do you hear commonly about EDS and HSD?
Well, a lot of those things that I was just talking about earlier is related to impact of the disease. And I think, we talk about invisible illnesses. I think that's a very good description. But I think that there's a better way that we can explain that as researchers and clinicians. And this is part of some of the research we're doing at the University of Virginia is to understand that at least if we can, try to add some clarity on the impact of disease, if nobody believes us that, that the symptoms are real and the symptoms are severe, how can we define it as the impact on someone's not only quality of life, but also what they do as an occupation? And clearly, there will very likely be an impact on their work, on their workability. And so this is some of the recent data that we've been collecting and how these conditions impact someone's ability to work, whether it's work hours lost or job promotions not achieved. There's a number of ways that we can look at it, and there have been other conditions too in similar sequence that have highlighted that. I think that's kind of like where we're going with it. So the long-term disability effect, as I was alluding to earlier, because I think that is a myth. I mean, yes, we need to put all the funding and effort into what we can to understand dementia and cancer and all of these other things, but there's certainly no reason to ignore this and minimize it because there's our profound effect on patients' lives.
And often very, very young people's lives. So they have many decades ahead of them. So if we can get them feeling better and functioning better, that's, a huge win for many, many decades. And if not, then, it is important for everyone, the family, the person to understand that, these conditions can be extremely disabling. So you're already researching this at UVA because you just started not too long ago.
Right, right. Well, these were some of the research ideas we'd already started from Mayo Clinic, and we've just continued on that. And I know others are interested in this too. So we have a large data set that we can interrogate, and I think that would be effective because really just as you mentioned, it's we as human society are really only as good as we can help those who are the sickest, who are the weakest, who are the most in need. And so, what can we do at least to highlight that there is a need here to begin with, and then we can focus that hopefully, more resources and funding and things like that into getting better research and better treatments and so forth into the future.
Fabulous. Let's shift gears a little bit and talk about dysautonomia and specifically POTS, because POTS, postural orthostatic tachycardia syndrome, is something that we see, of course, a lot in our patients with Ehlers-Danlos syndromes and hypermobility spectrum disorders, et cetera. So we know that POTS is often dismissed as, oh, well, you're just deconditioned. So what would you say to clinicians who think that POTS is just deconditioning?
Yeah, it is that and a lot more. And I think that is probably linked to some early research linking symptoms to, deconditioning, but reduced fitness overall, and then clinicians and the lay people then focus on heart rate changes. So we're getting like specific parameters and specific diagnostic criteria, and we can go into a whole nother discussion about that of the pros and cons or the advantages and pitfalls of diagnostic criteria. But one of the big pitfalls I would say is seen here in this area of POTS, and that is that the broader autonomic disorders and the broader systemic context is lost in that.
Yeah, that's really important because I think that sometimes people get sent to the cardiologist and the cardiologist may or may not do, orthostatic vitals in the office. They might do them briefly. They don't do them for the full, 10 minutes after the person is standing. And or even if they do diagnose the person with POTS, this has happened with a lot of my patients where they are left to believe that they have like a cardiac problem and not a neurologic problem. And like you said, not the actual systemic, like this affects your entire autonomic nervous system, which is the automatic nervous system, which controls your digestion, your breathing, your heart rate, blood pressure, et cetera. Temperature regulation is, of course, an important one in there. So yeah, I feel like it's so important for other providers to realize that, first of all, especially since we've had COVID, the COVID pandemic, that POTS and other forms of dysautonomia are much more common than they used to be, and that it is a spectrum like everything else. So it's really important to recognize when people are somewhere on that spectrum because there's a lot that we can do to help those patients.
Yeah, that couldn't be more true. And I think that once we understand, and there's some very good research coming into the COVID effects of causing autonomic dysfunction. And then I think that we then have a better understanding altogether that while the criteria is useful, certainly for clinicians and maybe those unexperienced clinicians to know when things are present or not present, we have then a better characterization overall outside of this criteria, what patients look like and kind of what their symptoms are. Because I think what we go back to a lot, and we want to encourage patients on this message too, is that the symptoms are there whether the criteria is there or not, right? And your symptoms are your symptoms. And so if it's the criteria that's an issue, then that's the criteria. That's not a fault of your own as a patient. It's upon us as clinicians to understand those and what those may be related to. And ultimately, how do we address them?
Yeah, most definitely, because that's the thing with the criteria. Okay, if your heart rate's supposed to go by 30 beats per minute, but your heart rate goes up by 28 beats per minute, does that mean you don't have POTS? And so that can be very frustrating for a lot of people. And I know people who have been assessed for POTS, told they had POTS, and then they went back for a follow-up and, did a repeat tilt table or something and said, oh, you no longer have POTS. And they're like, well, wait, what do you mean? What do you mean? I still feel terrible. So how could I no longer have POTS?
I was discussing this very topic too with some colleagues, and there's now some pretty good data on it, looking at those heart rate figures. And for some groups of younger patients, and they looked at using 100 beats per minute as a cutoff, which we typically define as tachycardia, right? Anything over 100 and above is tachycardia, is abnormal. Then the question is there difference in symptoms with that predefined tachycardia measure, or so anything above it or below it? And the fact was there was no difference in the symptoms and the overall presentation, just by that heart rate and the cutoff of 100 beats per minute. So, yeah, we have to be very careful when we make those judgment calls.
Right. And then the other thing that I'm thinking of as you're saying that, a lot of people, even if we, leave them supine and kind of usually I like to have people laying down for like 10 minutes before I check their quote baseline vitals before I get them up. But a lot of people are maybe anxious about the fact that you're going to be doing this, either a tilt table test or the orthostatic vitals. So maybe their heart rate's going to be faster than it would normally be anyway. So looking for that difference of 30 or 40 beats per minute, depending on their age, might be harder to find.
Or how about patients who have maybe already had some idea that this may be what they're suffering from, and they either take it upon themselves to learn about it and then treat it, and so it improves some of their symptoms and conditions a little bit. Maybe they're taking extra salt or fluid or things like that, and then they go get testing, and the testing is normal, right? And then what do you say about that? Well, okay, you're treated or you have the condition, right? And so being told that you don't have the condition is incorrect. So it's got a lot of nuance to it.
Right, right. And then I know there was a study that looked at patients with POTS, and they showed that at least in some people, their heart rate increase actually started before they actually did the tilt. And so they were saying, well, that must be psychologic. But if you also think about, there's a lot that it goes into your heart rate, right? And so there could be a conditioned response of, well, every time I stand up, my heart rate goes up, and now they're going to do this to me. So it's kind of like if you have insomnia and then you get in bed, you're not going to sleep well because you associate your bed with not sleeping well.
Yeah, exactly. Yeah. Yeah, and that's why in our best research studies we have to control for placebo and other variables as best we can, because it clouds the picture. And so just the same, it clouds the picture when it comes to diagnostic testing, and so yeah, we have to be very mindful of that.
And when it comes to POTS, as you were saying, clearly this is a multisystemic problem. It's not a heart rate problem, although the heart rate is definitely one of those things that we see impacted. I often do the Compass 31 as one of my like scoring tools or monitoring tools. Do you use that, or do you use something different? Because I know there are multiple different tools out there.
Yeah, actually, I use the Compass 31 too, and none of them are perfect, but I think it does give us some objective measures so that we can get an idea of what's going on. And I think that's really the way that we need to consider this, just the diagnostic testing in general, that it is added information. It's all sort of helping us paint a clinical picture, but we ultimately have to use our judgment. How do we piece that data together as clinicians?
Let's switch gears and talk a little bit about Mast Cell Activation Syndrome. Um, Talk about something that definitely can be controversial, right?
Oh yeah, that's right.
Yeah. It is so tricky because there are schools of thought where, you'd have to meet more strict criteria. There's schools of thought where, maybe we need to be capturing more people, casting a wider net because some of the treatments can be so safe. And why do you think that MCAS is so controversial?
Well, I think controversy lies in the lack of understanding and knowledge, just to start with, right? And lack of evidence. That's always a very vulnerable area to start a controversy between conspiracy theories out there and anything else, right? We start just conjuring up things out of thin air. So that's, I think, a starting point. So diagnostic criteria are out there, but they're still evolving. Testing is certainly imperfect. And then the symptoms themselves overlap with so many other things. When we're talking about mast cell symptoms, and you can't target just one organ or just one body system, because it can really, we talk about EDS and HSD being, connective tissue head to your toe, but, we kind of focus on musculoskeletal and things like that. But mast cell really goes just across the board as things that it can relate to and symptoms it can cause. So I think that's why. And I, am then an advocate of, let's do the research, let's get the knowledge improved, and let's understand these conditions better. And I think we understand them not by ignoring them, but by just looking into it and keeping an open mind, and bringing in all considerations as we can.
Yeah, totally agree. I mean, we need so much more research when it comes to these 3 components of the, if you wanna call it the triad or the trifecta. Some people call it the evil triad. It's so many people that are being impacted and affected, and their quality of life impacted, so we desperately need more research, more information, and that's why it's so exciting what you're doing at the University of Virginia, because I think your work already has helped a lot of people, but it's gonna help a lot more.
Well, and that's what we want to do, and that's what we want to do here with this podcast. Is we want to help and educate, and you had a very good session with Dr. Afrin, and I think that anyone who is brave enough to go into the field of understanding mast cell activation is doing a great service to us all, because as I just said, you can't shy away. Ignoring the problem is not going to make the problem go away. And it is a real problem when there is controversy, because what we end up with is this. Then we have really kind of 2 schools of thought, as you described it, and where we might call it consensus 1 or consensus 2, where one has been labeled as a group that's got very strict criteria and is underdiagnosing patients, and then that group sort of frames the other group as having 2 criteria that's too loose and overdiagnosing it. And whatever the case may be, patients are the ones that are left to suffer when they're on either end. When they patients are either being overdiagnosed or underdiagnosed. So we really have to narrow that gap. And I applaud, like I said, anyone who's willing to take the time to study it and look into it, because there is a lot of effort into understanding mast cell activation better. And I personally, is a shared similar approach to your guests who have discussed on mast cell activation, from Dr. Malin to Dr. Afrin, is that I personally just really just want to help the patient, and what can we do, to that end, that's safe and effective and is going to afford them the best outcome, um, you know, to get them back to functioning, with ease, without all of the symptoms that may be related to mast cell activation.
I agree. I often tell people, let's worry less right now about, do you actually meet the criteria for mast cell activation syndrome, or are we going to call this mast cell activation unspecified? And we're going to start to work on improving some of your symptoms, but let's, focus on the labels later and maybe think about, and I know some people would disagree with that approach. They feel like the diagnosis is important to establish first, but like you said, at the end of the day, it's about the patient and what can we do to improve their quality of life, because usually by the time they get to us, they're really suffering, and they've been suffering for many, many years, and in some cases, decades.
Yeah, it's exactly right, and that we don't want to see any more suffering. And I think you mentioned some people may say that that's not the right approach. I think the right approach is whatever we can do to help the patient, and the misconception, though, with taking the right approach or the wrong approach, is that, just like we were talking about genetic testing, if the lab tests are inconsistent or negative, the misconception is then the disease must not exist. The disease is not there. But the reality is that there are so many other complexities to these disorders that we're discussing: HSD, hEDS, and mast cell activation. They are biologically complex and episodic. And so the testing is not going to give us all the answers that we wanted to at this point. I'm hopeful for the future when we get there, but right now, we're not there.
Wow, you just hit the nail on the head. I think that's so, so important. I think that so often people think that we, live or die by the test results, but every test has limitations, right? Whether it's imaging that we're doing or labs or whatever the case might be. So that's so important. You said this at I think the beginning of our last conversation about listening to the patient, and William Osler, the quote, listen to the patient, they're telling you the diagnosis.
Yeah, that's it. And, we have to think about every patient, because every patient has a different story. And then, I hate really the concept of spectrum diseases, it's autism spectrum, hypermobility spectrum, because I think it exhibits our lack of knowledge, and we just throw a spectrum out there and it captures everyone. And eventually, I am hopeful that we'll get to a point where we actually have better classifications. But right now we do have to understand that it is a spectrum because there are certainly different presentations, some with more severe presentations, some with milder presentations, and so we as clinicians have to understand the clinical patterns and the treatment response that may be elicited with whatever treatment tools we have in every individual setting.
Well, we're going to take a quick break. And when we come back, we are going to talk about more myths about MCAS and also about pain. So we will take a quick break and we'll be right back. I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. We're back with Dr. Knight, and I just wanted to talk a little bit more about mast cell activation syndrome and mast cell activation, just because I feel like this is an area that is so full of myths. Now, I'm thinking back to when I first heard about mast cell activation syndrome, and I was thinking, now, wait a minute, it feels like they're lumping just everything, right? Like you could have constipation, you could have diarrhea, you could get full easily, you could eat a lot, you could gain weight, you could lose weight. Like, wait, this is like everything. So, how do you think we should be thinking about mast cell mediated disease?
Well, I think we should start with that thought in mind that there's a lot of things that can be lumped together. And that's generally the approach we take with matters related to EDS and HSD is that there can be so many things that it's causing. So we want to start with by casting the widest net, right? To try to include as much as we can. We talked about Occam's razor before and so on. Um, but in doing that, then that net is also meant to be cast to catch anything else that could be causing those symptoms. So we're looking at other organic dysfunction in the body, so other organ systems, other autoimmune diseases, other allergic immunologic conditions that can kind of fold into it. So I think that's the right approach to take. I think we do lump in things in general, but what we want to get to is a point of like, okay, we can work on differential diagnoses all day long, but what is that going to get us towards the next step in getting to treatment? Fortunately, and I would say in this area of controversy related to mast cell activation syndromes, that there's a variety of treatments can be used, and fortunately, some of the first stages of treatment are relatively safe. So, I'm comforted by knowing that we can start with some treatments that are safe and easily accessible enough, and we can find some responses in those patients. So that is reassuring. But there can certainly be more severe cases that are treatment resistance, and then it gets pretty quickly tricky.
And it makes sense, right? Because mast cells are present where we interface with the environment. So in the skin, in the digestive tract, in the genitourinary tract, it can create a lot of havoc in the body. And of course, laying next to nerves and affecting connective tissue. So, we know that this is so intertwined, which of course makes it really challenging to sort things out. But it's also a very exciting time, I think, to be in this space.
Well, yeah, and that's really what excites me the most about what we're doing here at the University of Virginia. What I am working with other colleagues at other institutions across the country, and my colleagues still there at Mayo Clinic, and that is understanding the human body, but the human condition better in general. And we are far from knowing everything there is that can be causing problems and symptoms in any human being. And if we get to a place where we are understanding the pathophysiologic mechanisms, meaning the steps and sequence to disease, and and we get a better understanding of that, then when we get to better treatments, I think we get to a better understanding that we are better at having precision medicine at our disposal. We're better at understanding one individual condition, an individual experience versus another, based on, you hear about the omics, so their proteins, structures in their body, their genetic condition and makeup in their body, the exposures, the environmental conditions that they've been exposed to, and so there's so much that we can do with that, and that's what really excites me the most about this research and going into this field is I think that we're unlocking some very big answers for anyone who's working in the medical field.
Most definitely. I also want to talk about pain because we know that that is such a common presenting concern with a lot of patients that have hypermobile EDS and HSD, especially, but of course, other forms of EDS as well, and other connective tissue disorders like Marfan syndrome, Lewy Dietz, etc. So I know that when I first learned, and I was working as an anesthesiologist, I was in practice for a number of years, but I was having so much pain myself. And I actually watched a lecture by Dr. Dan Claw, who you probably know who he is.
Yeah.
Yeah, fibromyalgia guru. So I was watching a lecture by him on YouTube, and it just blew me away because I hadn't really studied about pain processing for, many, many years since my residency. And when I heard that, pain does not equal structural damage, that there's all these other factors involved in pain processing. That was really a pivotal moment for me in improving my pain that I had in my body. And I think this is one of the biggest myths that is important to correct. It's not that it's not that you're making it up. It's not that it's quote in your head, but it's not quote like in your head as in you made it up in your head. But I think understanding that you can have damage in your body, but not have pain, and you can have pain and not have damage is, I think, a very important concept for people to understand and an important myth to discuss.
Well, yeah, absolutely. And this is a huge paradigm shift in medicine in general, in our understanding of pain. And I don't think that we've really grasped it all. And I don't think we accept that shift so much in medicine and healthcare. And, really, I should ask you, Dr. Bluestein, since you're the expert on this. I've actually learned a lot from the papers you've written on this. But I think this is where a lot of our patients get misunderstood. And as you mentioned, so thinking about pain as structural damage, and there must be a smoking gun somewhere, right? And in the cases of our patients with these hypermobility disorders, there's not a smoking gun, but yet there still is something there, and we are actually getting better at characterizing that and studying the conditions of pain in the lab. And I guess um, this is my offer to you to share the understanding of our progress in characterizing nociplastic pain over the years.
Yeah, it's fascinating because nociplastic pain is okay. So there's the different types of pain, right? There's nociceptive pain, which is more directly related to actual or potential tissue damage, neuropathic pain, pain that's in the nervous system, and then nociplastic pain, which is more like the software of the nervous system, kind of being dysfunctional. And you can have nociplastic pain though, and you can have nociceptive pain. So maybe you have arthritis in your knee or you've dislocated your patella many, many times. And so you've had these pain sensations, the nociceptive neurons, sending pain signals to your brain, and then that sensitizes your central and peripheral nervous system. But what's fascinating about that is how the mast cells are involved, and mast cell mediators, how they're involved in pain processing. So oftentimes what starts the problem and what perpetuates the problem are not one and the same, but by treating the mast cells, oftentimes we can make the pain better. So I just think it's so interesting to learn about, like you said, any of these things and how everything is interconnected. And look, for me, learning about pain processing and how, like, I was at that time, I was doing so much catastrophizing, and by changing how much I was catastrophizing, like, that could change my experience of pain, because pain is an experience, right? It's not something that it's whatever the person who is experiencing it says it is. And so there is no such thing as, non-real pain. All pain is real. And, it's it's though involved in so many different factors. So it's not purely psychologic. I feel like there's like camps that are like, it's purely psychologic. No, that's not true. It's purely biologic. That's not true either. It's biopsychosocial. So we need to recognize all of those factors involved in pain if we want to help people have less pain and function better.
And that's what comes to my mind a lot too, that it is an experience. So maybe you can add to that too why we can't measure pain. There's not a simple answer to that, right? But there's so many things that are involved in pain, right?
Right. There's so many things involved in pain. And a lot of people think of pain as just like going from the periphery to the brain. So there's that classic example where a person is like, has their finger close to a fire and the pain signal is going from their finger up to their brain and tells them, oh, move your hand, right? But pain signals also go from the brain out into the periphery. So we can actually either dampen those signals or we can amplify them depending on what's happening in our nervous system. So it's important to understand that pain is bidirectional. And the research in this space now is really, really fascinating. And the fact that the centers of the brain that are involved in pain involve things like the amygdala, which is the fear center of the brain. So when we are more fearful, we are going to feel more pain. And I remember when I was in so much pain and I was still working in the operating room and I was really kind of struggling and having a lot of problems. And I remember my doctor saying things to me like, well, you need to do deep breathing or, it's like, okay, well, that's not very helpful. And not understanding that stress affects all pain. So it doesn't matter what the pain is coming from, but when we're more stressed, we are going to feel more pain. Our pain experience is going to be worse. So there's things that we can do that can make the pain experience worse. There's things that we can do to make the experience at least a little bit better. So learning some of those tools can be really, really helpful, like some of the neural retraining type programs that are out there. There's quite a few, and I've had a lot of people have really good success with those, as well as medically treating things. And we're going to be talking next time about our favorite treatments, and I'm excited for that conversation.
Definitely. I mean, this is just a fascinating conversation in itself, and I have as well had patients that have had success with this pain neuroscience education and things like that you're describing, and we love those success stories because those are generally accessible, and we're not talking about major surgeries and things like that to find improvement. So I love those stories of success for sure.
Yeah, me too. I mean, it seems like what they're doing. They take different approaches, right? But trying to teach the nervous system that the body is safe. When we're in that sympathetic mode, we tend to feel more pain. We're going to feel more anxious, and then that kind of feeds onto itself and can, really exacerbate the problems.
And that's why it's so difficult to, when we talk about advancing technology and improving our resources and capabilities, we don't have a biomarker for pain. We can't image it. We can't get a lab test for it because there's so many things that it's connected to, right? And things are influenced by so many other things in what you're describing. Even just stress, like, if something relates to stress, then how can you control for that every time?
Yep, exactly. And that leads perfectly into my next question, which is in terms of like frequently asked questions and myths that we hear a lot, why symptoms fluctuate so dramatically. I think a lot of times family members don't understand. They think, oh, the person must be exaggerating or faking or something if they can be pretty good one day and then really, really miserable the next day.
Yeah, and that's what we ultimately want to get at, is to get to a place where patients have less of these cycles, or less of the flares, and I think we get to that by first educating, and then patients understanding their own condition and their own bodies and their own behaviors and what may lead into those cycles and those flares, because there's a lot. And going back to mast cell treatments too, we talk about all the things that we try. One of them is try to avoid triggers. Like, okay, that's certainly easier said than done. If you can, though, if you can identify triggers, great. But I'd say it's the same thing with flares and with symptoms. And there can be any number of triggers when it comes to flares, whether it's a POTS flare, whether it's a mast cell flare, whether it's pain flare, fatigue, brain fog, and those things are usually related to the day to day. activities that someone is doing, and they can be very small too. And we have this description of the chaos theory by the butterfly flapping its wings, and butterfly flaps its wings, and somewhere along the way there it causes a tornado. And I think that's the best analogy we have here in these cases, that the butterfly flapping your wings in a day-to-day life may be you were exposed to some allergy you didn't know you were exposed to, or you didn't sleep well and you may not even notice it because you just didn't sleep well and your body was in pain, and maybe it wasn't enough to wake you up, but your just quality of sleep wasn't that great. Any number of those things can just be minor issues that have manifold effects down the road or into the next day.
Yeah, I love that example because I don't know if this happens with you, but this happens with me all the time where I have a patient that I'm talking to and they're telling me that, their symptoms are worse. But not only are their symptoms worse and that's bothering them, but what bothers them even more is that they can't figure out why.
Yeah.
And
Yeah.
and of course, sometimes we're not going to figure out why no matter what. Other times, as you start to dive into it more, they might actually realize, oh, actually, I did do more than I thought. And like you said, it could be a really small thing. But have you observed that in your patients that not knowing cause and effect? I guess it makes sense for human nature that we want to know why this thing occurred so that we can maybe change the outcome next time. But do you see that?
It adds to the frustration, right, with the condition that they're already experiencing, and so much frustration involved in it already, and frustration with the healthcare system, frustration with their symptoms, frustration with lack of control. And so that in turn is only going to add to stress levels. And we just, I think, related very well, as you just described, that the stress can cause compounding effects on the body. So increased cortisol, glycemic control issues, blood sugars all over the place, sleep is all over the place. And when we're in already this very careful balance of, homeostasis, of your body is trying to reach this point where your circadian rhythms are on point, your sleep wake cycle, when you feel tired, when you feel awake is on point. Any slight thing that pushes it over the edge is just it's going to lead to a tornado. So I think that's, why we have to, again, put a lot of the emphasis on patients getting to the point where they understand these conditions and the effect they may have on their body. So then they learned how to recognize patterns within their body and with things that they're doing, and where those patterns may lead into symptoms. And it's not easy, but we have to start somewhere.
Yeah, we definitely do. And also, we know that a lot of people with EDS and HSD react poorly to medications or react poorly to supplements. Do you have any thoughts about that?
Well, yeah, and it just like we're talking about flares, and everyone's experience with flares can be different as far as what triggers and what kind of conditions they're living in, what kind of stress or jobs they're doing. And it's the same thing with medications. Now, those may not be affected as much by behavior and daily activities and things like that. But there is certainly a lot of differences from one person to the next, how they're metabolizing medications, how they're taking them, what they're taking them with, any other medications they're taking them with. So, and as an internist, I see this a lot. I get asked this a lot too. What kind of medication interactions that may be present? So that's something we have to take our time with the patients, and also why we want to avoid polypharmacy to begin with, which is just description of excess medications. You're taking one medication to counteract another medication, and you're taking another medication to counteract that, right? So I think we have to start from the bare minimum and understand that everyone's response may be unique. So a failed response is not necessarily that it's a failed treatment. It's just an opportunity to find a different treatment or a better treatment.
Okay. And what do you see as the mistake that providers make most frequently? We know that we talked before about how a lot of times people are not very curious. And so that's something that people could work on, being more curious and being more open minded and not minimizing people's symptoms. But if you had to pick one thing, what do you think the biggest mistake is that most clinicians make?
Well, I think it's I think it's a mistake that when patients come in with these conditions, that there's so much complexity to it that it's almost like analysis paralysis that clinician looks at all of these things going on, and so immediately just this shuts down, like this is more than I can handle. And I hear patients say that all the time. And so, the physician just, they just outright don't accept patients with mast cell activation, and outright don't accept EDS. And I understand that the complexity is there, and it's frustrating as a clinician if you don't understand how to treat something or address it correctly. Then you feel like you're not doing your job. You're not, we go into this to try to help people, and if you can't help someone, it's frustrating. But I don't think the answer is that you just, ignore it or push it away or send it on to the next person. I think that we have to keep an open mind about what symptoms may be caused by. And I think we then have to at least take some time to understand these. This is what we're doing. So we're trying to make this understanding, something that's within grasp of clinicians, that, in the end we realize that there's lots of complexity to it, but there are also patterns within these conditions, and there are also treatments, and there are success stories. And it's so rewarding to me to find patients who have gone through so many hoops that don't get anything, and then we find successful treatment. And I think that that's something that would be shared by many other clinicians, this sense of satisfaction reward when you treat someone correctly.
I love that, because I think that is what has kept me going as well, is, those success stories that you have in there, and it just makes you feel like, yeah, that's why we went into this profession in the first place, right? So it is really rewarding, and I think you're right that there's maybe a component almost of learned helplessness that can happen, where you look at all of these symptoms and you think, oh my God, there's just no way. There's just no way that I can do anything for this person.
Yeah, and so you're certainly not going to do anything by just ignoring it, and you're not going to do anything good by just sweeping it under the rug.
Maybe if nothing else, if people can say, I believe you, I hear you, I don't know how to help you. I don't, if you don't know enough to even like point someone in the direction of resources, I certainly hope people will point people in the direction of this podcast. And the UVA Center would obviously be another great resource. But if nothing else, I think that just simply saying, I believe you, really means a lot for a lot of patients, because I've had a shocking number of people tell me things like, well, I can't be in this much pain because my doctor told me that I shouldn't be in this much pain.
Yeah. Well, that's a real gem you hit on, Dr. Bluestein, and I agree. I think the way that we frame this is that we as human beings are all worthy of love and compassion, and as doctors, that's generally what we want to provide. So there are some things that are within reach that can show love and compassion, and and as far as education goes, I think this is a good opportunity for me to make a plug for our research symposium that we'll be hosting at University of Virginia. So yeah, that's April 9th and 10th, and we will have virtual option for attendance. Registration is free, but we have some excellent speakers from all over, and we would love to share the knowledge and education that we'll be hosting. So we can get that registration information into your show notes here.
We will definitely add the link to the show notes. And is this a symposium for providers? Is it for patients? Who is the intended audience?
Yeah, well, it's funny you asked that, because we built this as a research symposium, because we were talking about there's so many research opportunities, there's so much research going on, there's so much that we want to share and discuss. But there's also clinicians who wanted to be involved, and they're seeing patients. We know that clinical care is evolving too. So researchers and clinicians, and then our patients started getting wind of this, and we realized that there's so much patient interest, and that's great. And there's so many knowledgeable patients out there, and patients who are hungry for knowledge. So it's really geared to all of the above. So researchers, clinicians, patients, community members, all of the above. We want to make it accessible and understand all of those things that help all of those groups of people.
Amazing. I'm really looking forward to that. That's going to be a lot of fun. That's going to be a great event. So that's fantastic. So on this podcast, we have now hit over 1 million streams, which is very exciting. And some episodes have been listened to by, tens of thousands of people. So I would love for you to share what you think patients should be doing differently. Like kind of one big thing that you think that if patients could do differently, it could maybe make a significant difference in terms of their outcomes.
Yeah, and by adding this in, I certainly don't want to bring up too much anxiety to someone that they're doing anything wrong because the added anxiety is certainly self limiting on its own. But yeah, as far as a DIY pro tip, I would say that as we referred to earlier in this episode, that getting to understand your symptoms, the condition that your symptoms present in, characterizing those and what those may be related to. So, whether it's a journal or just, even just taking mental notes and taking notes on your phone, that's probably a very good way of doing it because it does two things. One, it's something that you share with the provider so that they're not just like, in this analysis paralysis, they've got some objective things that they can look at. They can't brush this aside as too complex or non-specific. And the other thing is it helps patients to also grasp the understanding of how things may relate to one or the other and how it may relate to your body. Because really, ultimately, as we said before, is we want to empower patients with these skills and the self-management tools. And their own bodies and their own experiences are so unique that we have to keep the patient as the focus and as part of the treatment team itself to achieve the best outcomes.
Yeah, I love that. And I have a hack. If you don't, we always end with a hypermobility hack. If you have one, great. Otherwise, I have one.
Go for it.
Okay, so it's funny because my hack actually fits very well into what you just said. We're already starting to think alike. That's a little scary. So my hack is that when you are telling your story or reporting your symptoms or explaining your conditions, it's helpful to have like layers in different versions. So you might have like the half page, 2-minute version, like just a few sentences. And then you have the little bit longer version. And then you have like all the details that if somebody wants 50 pages, you're going to have that. If somebody wants your whole binder, you're going to have everything in your binder. You're going to have your imaging, your labs, all of that stuff. But be prepared to have multiple different, ways that you can tell your story so that if somebody needs the key pieces of information in a very short time, you can do that. If they have a little bit more time, you can do that so that you can be concise, but yet share the details that the person needs. And ideally, if you can do this using like a detective type lens and a curiosity type lens and trying to act like a reporter so that you're reporting more the facts of like, this is what I feel rather than labeling, okay, I have this CSF pressure headache. I have this CSF leak headache. I don't know about you, but I really like people to tell me like what it is that you feel in your body because otherwise we might prematurely label something and be headed down the wrong path when in reality, maybe it's something completely different that's causing your problems.
Yeah, I love that. I love that idea too of having what you might call an elevator speech, right, of your situation and condition at the time. And so in the setting, whether it's someone in a healthcare setting that you may not have much time with, how you can get that to them, or we talk, you'd see on Reddit something, right? Too long, didn't read. So you've got the TLDR right there, ready to go, but then you've got all the details to back it up. That's great.
Yeah. And I know you mentioned that you gave a talk recently on AI. Well, AI could be a great tool for this. You could take your whole, all the stuff, the really, really long version, and you could ask AI to help you reformat it because AI is really good for reformatting things. You obviously have to be careful when you're using it for a lot of other things, but for reformatting, it can be really great.
Oh yeah, we've talked about this in the setting with HEDS and HSD because we then patients develop such a long, complex story, and I've had them. They plug it in, they get their large language model of choice and spit out a summary, and it's delivered to me like packaged perfectly. It's so easy to understand. So I love it. It's great.
Yeah, it's great for us because it'll have like neurologic and then, depending on how you want to format it, but you could have that help you break out your symptoms by system. And that can be really, really helpful for your provider to actually be able to look at that and very quickly get a sense of what's going on. So,
Yeah, and as a place to continue questions and ask things that as it may relate to any of those topics. But yeah, good to have as a map, as a roadmap to go through for that visit.
Absolutely. Well, thank you so much for joining me again today. As always, I really loved this conversation, and I know that you have a lot going on. I'm so excited about the symposium, so thank you for sharing that with us. We'll be sure to put a link in the show notes so people can learn more about that. And of course, we will also include the phone number and the links to learn more about the UVA Health, EDS, and Hypermobility Disorder Center.
That's great. That's wonderful. Yes. Thank you so much. It's exciting to see where this goes, and I'm looking forward to our next conversation.
Well, as always, I really enjoyed talking to Dr. Knight. He is such a wealth of information and has such different perspectives, so it's really great to get to talk to him. Thank you so much for listening to this week's episode of the Bendy Bodies Podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at hypermobilitymd. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.